Do you know that our cardiac muscle beats about 100,000 times every day? It keeps on beating when we are awake and when we are asleep. Unlike your mobile phone, it does not need any charging. And unlike our skeletal muscle, it does not need any conscious effort or voluntary involvement for its contraction. Our cardiac muscle does so because of the fascinating electrical potentials which are occurring in our SA node of heart and the ventricular muscle. These action potentials develop in the SA node of heart spontaneously, which means it does not need any external stimulation, unlike the skeletal muscle. Your skeletal muscle cannot contract if it is not stimulated by a nerve fiber, but our cardiac muscle can auto stimulate itself. So this electrophysiology of heart, which is the action potential in SA node and the ventricular muscle, this is one of the basic foundational concepts of the cardiology. So what will happen if these electrical potentials in the heart do not happen properly? Let's explore it. Today we are going to study the action potential of ventricular muscle and the SA nodal fiber and the ionic mechanisms involved in their various phases. We will also study the differences between action potential of SA node and the ventricular muscle, and we will also study some clinical conditions like some arrhythmias which can occur because of some problems with their action potentials, and also we will briefly talk about some drugs which affect various phases of action potential of SA node and the ventricular muscle. Now first let's talk about the phases of action potential of a ventricular muscle. This is the diagram of action potential of a ventricular muscle fiber. It has got some phases: phase 0, 1, 2, 3 and 4. Phase 0, which is the first phase of action potential of ventricular muscle, this is because of opening of fast sodium channels. So when sodium channels open, there is entry of sodium into the cell. So you know that sodium has got a positive charge. When positive sodium ions enter into the ventricular muscle, this is responsible for rising the membrane potential from negative value towards less negative and then towards a positive value. So during this phase 0, which is the depolarization phase or upswing of the action potential, this causes membrane potential to go up to plus 20 millivolt. On y-axis we can see the membrane potential is expressed in units of millivolt. So at the peak of phase 0, you can see the sodium channels are closed, and now another phase starts, which is phase 1. This is also called as early repolarization or initial repolarization. During this phase, another channel opens, which is potassium channel. Potassium diffuses from inside of the cell to outside. Potassium is a positive ion. If it is losing from in to outside, so what will happen? Inside will become less positive. So that's why the membrane potential falls from plus 20 millivolts down to about 0 millivolt. So positivity decreases inside the cell. But this is a brief phase because it is followed by another phase of action potential, which is phase 2, and during this phase calcium channels open. These calcium channels, we can also call them slow calcium channels because they are slow to open and they remain open for a long period of time. So this phase 2 is also called as plateau phase of action potential of a ventricular muscle. During this phase, calcium moves from out to inside of the cell, and because of this calcium passing from out to inside, because of positive ion, it will keep inside positive, so that will remain depolarized. So you may think, because positive ion is coming inside the cell, why the membrane potential is not going up, it's staying at the 0 level. It is because during the plateau phase, not only the calcium is coming into the cell, but some potassium is also leaking from in to out. So this potassium which is leaking from in to out during phase 2, that is balancing the calcium which is entering into the cell. So this is why potassium, positive ion leaking from in to out, calcium coming from out to inside, these two ions, they balance the membrane potential. So that's why membrane potential stays almost at the 0 level. But keep in mind, this plateau is part of depolarization. This is not part of repolarization. Rather, this plateau is part of depolarization, and this is responsible for prolonging the action potential of a ventricular muscle fiber. Now the final phase of the action potential of ventricular muscle is phase 3, which is also called as final repolarization phase. So you can see here, during this phase, potassium efflux is occurring because of diffusion of potassium. It will make inside of the cell less positive. So you can see here, gradually it becomes less positive and it comes back to the resting value. So phase 4 is the resting membrane potential phase of the action potential of the ventricular muscle fiber. So when it reaches back to the resting membrane potential, then it is ready for the next action potential. It can be re-excited and the next action potential can start from here. If you are interested to know the factors which generate the resting membrane potential, you can check this video. There is a mnemonic to memorize various phases of the action potential of ventricular muscle fiber, and the mnemonic is never in Canada, please relax. So in this mnemonic, N is for sodium. So during phase 0, it is sodium which is passing from out to inside of the ventricular muscle cell. During phase 1, what is happening? It is the initial repolarization phase, during which potassium efflux is occurring. During phase 2, it is calcium, Ca for calcium, which is entering into the cell, passing through the slow calcium channels. This is the main factor responsible for the phase 2 or the plateau phase. Please keep in mind, plateau is the most important phase in the action potential of the ventricular muscle fiber, because this plateau phase prolongs the action potential of the ventricular muscle fiber, and this plateau phase is part of depolarization. This prolongs the excitation of the ventricular muscle fiber. This P is for potassium, which is leaking out of the cell during phase 3, and this R is resting membrane potential, which is phase 4 of the ventricular muscle action potential. It is also interesting to know that in ECG we have got some waves, and those waves in ECG, like P, QRS complex and T waves, they are because of various phases of action potential of SC nodal fiber and the ventricular muscle fiber. This action potential of the ventricular muscle fiber is analogous to working of a flashlight. When we turn on a flashlight, that is analogous to the upswing of the action potential, which is the quick depolarization. This initial repolarization of the action potential is just like the flashlight, which can quickly become dim. And this plateau phase or phase 2 is like the flashlight, which stays on, but slightly less than the full light. And this repolarization is like the battery is being drained, and when it comes back to rest, then it is ready for another cycle. So how this action potential of the ventricular muscle fiber is compared to the action potential of skeletal muscle fiber? In case of skeletal muscle fiber, the action potential is like this. It goes up and then comes down. I mean the depolarization and then repolarization. So this action potential duration is like 5 to 10 milliseconds. But the total duration of action potential here in case of ventricular muscle fiber, this is about 250 to 300 milliseconds. And same is the duration of refractory period here, which means that if one action potential is already occurring in the ventricular muscle, the next action potential cannot be started unless the first come to the resting value. So the refractory period in case of ventricular muscle fiber is almost equal to the duration of action potential, which is about 300 milliseconds. So we can say that almost 3 to 4 action potentials can be generated in 1 second maximally in our ventricular muscle fiber, because there are 1000 milliseconds in 1 second. But in case of skeletal muscle, because the duration of one action potential is about 5 to 10 milliseconds, so we can generate up to 100 to 200 action potentials in 1 second if we rapidly stimulate our skeletal muscle fibers. Every action potential follows one contraction. So because in case of skeletal muscle, there can be rapid stimulation because of rapid rate of action potential which can be generated over there. So that's why those rapid contractions, they can be added up, which can give us catenization. Catenization means the contractions, they are added up, and the successive contractions are added up, and this sustained contraction without relaxation is called as tetanus or tetanization. Fortunately, this tetanization is not possible in case of ventricular muscle fiber because of its long refractory period. What will happen in case of ventricular muscle fiber if the plateau phase is disappeared? So because of this, if plateau phase disappeared, the total duration of the action potential in the ventricular muscle, that will decrease. If shorter will be the duration of action potential, shorter will be the refractory period. Hence, more number of action potentials can be generated in 1 second, and hence more number of contractions in 1 second. So those nearby contractions can be added up, and they can give us sustained contraction without relaxation, which means that heart will not get time for filling of blood. And also because the duration of action potential will shorten because of not having a plateau phase here, so there will be contraction of heart for short period of time that will decrease the efficiency of pumping. It is the plateau phase which gives a longer uh, stimulation to the cardiac muscle, and also during this phase more calcium enters into the cell. This calcium is responsible for forceful and efficient contraction in the cardiac muscle. If plateau phase is not there, the contraction will become weak and less blood will be pumped out of heart. This presence of plateau in the ventricular muscle action potential, this also prevents serious arrhythmias in the ventricular muscle like ventricular tachycardia and ventricular fibrillation. But if the plateau phase decreases, then the duration of action potential will decrease, and then the same impulse in the heart can re-enter or re-excite the cardiac muscle, and that re-entry or circus movement of cardiac impulses in the heart can lead to some serious arrhythmias like ventricular tachycardia or ventricular fibrillation. Now let's talk about the action potential of SA nodal fiber. This is the action potential of SA nodal fiber. SA node is a modified cardiac tissue in our right atrium of heart. SA node is the pacemaker of heart, and this is responsible for automaticity and rhythmicity in the heart. Automaticity means the cardiac muscle is able to produce its action potential spontaneously without any external stimulation. And rhythmicity means the action potentials which are produced in the SA node of heart, they are regular and with equal interval in between. So these two properties collectively are called as autorhythmicity. So it means the cardiac muscle is autorhythmic, and this is mainly because of the SA node, which is modified cardiac muscle, and this is not a nervous phenomenon. The cell membrane of SA nodal fiber, this is more leaky to sodium as well as calcium. This is why, because positive ions, sodium and calcium, they keep on leaking into the cell because of diffusion. That's why the resting membrane potential of SA nodal fiber is less negative as compared to the resting membrane potential of the ventricular muscle. You can see here in the ventricular muscle, resting membrane potential was minus 90, but here the resting membrane potential in SA node is minus 60, and this is because of increased leakiness of its membrane to sodium and calcium. Because sodium and calcium, they are positive ions, when they keep on entering into the cell, those positive ions, they decrease the negativity inside the cell, so its resting potential, instead of being minus 90, is actually minus 60 millivolts. Secondly, the resting membrane potential of SA nodal fiber is not stable. It slowly drifts from minus 60 to minus 40, and this minus 40 is the threshold value. At this point, when it reaches, then it spontaneously fires, which means the depolarization starts spontaneously. And this unstable resting potential of the SA nodal fiber, this is also called as pre-potential, or we also call it pacemaker potential, because it is the slope of this unstable resting potential that determines how much will be the heart rate. The early part of this pre-potential is because of leakiness to sodium, and this is called as funny sodium current. And the later part of this pre-potential is because of leakiness to calcium. So calcium diffuses from outside of the cell to inside of the cell. These are special type of calcium channels which we call as T type of calcium channels. So you can see here that during the initial part of the pre-potential, this is sodium ions which diffuse from outside of the cell into the cell through the acinodal cell membrane, and during the later part of this pre-potential, this is calcium which passes through the T type of calcium channels from outside of the cell to the inside of the cell. So you can write a number 4 here, that this pre-potential or unstable resting potential of the SA nodal fiber, this is phase 4. Just like we have studied that in the ventricular muscle action potential, phase 4 was the resting membrane potential, and that is actually stable resting membrane potential. But here in this case, phase 4, which is unstable resting potential. Early part because of funny sodium current, and the later part is because of passage of calcium from out to inside through the T type of calcium channels. The next phase is phase 0, and this is because of opening of L type of calcium channels. So calcium passes from out to inside of the cell because of diffusion. So you can see here calcium is entering from out to inside of the cell. These are different channels which we call as L type of calcium channels. During the pre-potential, the channels involved were T type of calcium channels. Please keep in mind the depolarization in the ventricular muscle is because of opening of fast sodium channels, and here these are slow calcium channels. So this is what depolarization here was a bit more steeper, but depolarization here is relatively less steeper because these are a bit slow type of channels. The next phase is repolarization, which is phase 3. During this phase, potassium passes from inside of the cell to outside along its concentration gradient. So this is potassium efflux or potassium diffusion from inside of the cell to the outside. And because potassium is a positive ion, when positive ion moves from in to outside, inside will become less positive or it will become gradually more negative, and it will come back to its resting value, which is minus 60, and then this cycle will start again, which means that from minus 60 it will gradually and slowly drift to the resting value, which is minus 40. Once we touch that threshold, which is minus 40, once again depolarization will start there. So that depolarization will be the firing or the start of excitation, and then repolarization will occur, and this process will keep on happening again and again by itself. So that's why we say that SA node is the automatic tissue in our heart, and that provides the property of automaticity. And because of this property, of cardiac muscle can generate its signals by itself without any external stimulation. So this automaticity property of our SA nodal fibers is analogous to an alarm clock which can reset itself every day without need to be manually turned on. So you can see here the pre-potential is responsible for bringing the membrane potential back to the threshold value by itself. This is just like alarm clock is resetting itself every day without any need to be manually turned on. There is a mnemonic by which you can easily memorize the ionic basis of SA nodal action potential. This is 4 cats, 1 king. F in 4 is for funny sodium current, which is responsible for bringing the membrane potential from minus 60 to minus 40. So it means this is for phase 4. In cats, Ca is for calcium, that's for phase 0, because during phase 0 it is L type of calcium channels which are responsible for depolarization to occur. And this 1 king is actually for potassium, because potassium has 1 plus charge, and this is for during phase 3. Potassium efflux is occurring, which is causing repolarization of the SA nodal fibers. You may be asked this question in your examination, that SA node is able to generate its signals spontaneously but not the ventricle. What is the reason? The reason for that is the resting membrane potential of ventricular muscle. This is stable at minus 90. But in case of acinodal fiber, the resting membrane potential is less negative at minus 60, and this resting potential slowly drifts from minus 60 to minus 40 by itself because of sodium influx and then calcium influx through the T type of calcium channels. And this pre-potential brings it to the threshold value, and then it starts the depolarization, because this process is happening again and again by itself. So this is why our SA node can spontaneously generate action potential, and this is why it is our pacemaker of our heart. But because in case of ventricle its resting potential is stable, so it cannot come by itself to the threshold value. So this is why it cannot generate spontaneous signals, but SA node can generate spontaneous signals. You may also be asked, what is the relationship of this unstable resting potential with the heart rate? Actually, the slope of this pre-potential, it determines the heart rate. More steeper is the slope of pre-potential, like this, faster will be the heart rate, and less steeper is the slope of pre-potential, slower will be the heart rate. I will talk about sympathetic and parasympathetic stimulation. These are two types of autonomic nerves. The hormones and neurotransmitters of sympathetic nerves, epinephrine and norepinephrine, they make the cell membrane of acinodal fiber more permeable to sodium and calcium, and hence the slope of prepotential increases. Because the slope increases, so it takes less time to reach to the threshold value, and hence the heart rate is increased. In case of parasympathetic nervous system or the neurotransmitter acetylcholine, it makes the membrane more permeable to potassium. So that's why the slope of prepotential decreases, and it takes more time to reach to the threshold, and hence the heart rate will be decreased. You should also know the differences between the action potential of ventricular muscle fiber and the action potential of acinodal fiber. The first difference is that resting membrane potential in the ventricle is stable at minus 90 millivolt, and here the resting membrane potential is unstable at minus 60 millivolt, and it gradually drifts from minus 60 to minus 40, and this unstable resting potential is called as prepotential. Second difference is that the depolarization phase here in ventricle muscle is because of sodium influx, and this is a bit more steeper because these sodium channels are fast to open. In case of acinode fiber, this depolarization is because of opening of L type of calcium channels. They are relatively slow to open, so that's why this depolarization in SA node phase 0 is relatively less steeper. Phase 1, which is early repolarization, and phase 2, which is plateau, these two phases are present in the action potential of ventricular muscle fiber but not present in the action potential of SA nodal fiber. So phase 1 and 2 are missing here in SA node. Because phase 2, which is the plateau phase, that makes the action potential of ventricular muscle longer. This is why the ventricular muscle has longer action potential, which is of a duration of 300 milliseconds. But in case of acinodal fiber, because plateau is not present, so that's why the total duration of action potential here is about 150 milliseconds. So almost this is of half the duration of ventricular muscle action potential. Another difference is between the overall shape of their action potential. The overall shape of action potential of ventricular muscle is like a tall mountain with a steeper depolarization and a plateau there and a slower descent or depolarization. In case of SA node, the overall shape of action potential is like a smooth hill with slow upward depolarization and slow repolarization. There are no steeper phases here in SA nodal action potential. Now we will talk a little bit about some clinically relevant points. What will happen if the SA node becomes dysfunctional, like in case of SA nodal block? In this case, because SA node is not generating action potential, it won't be acting as the pacemaker of heart. There are some other tissues in our heart like AV node that will be acting as a second pacemaker. It is just like a backup generator. If we are not getting power at our house and if we have a generator, so that will be switched on, but in this case the AV node is like a slow generator which will give a pace to our heart, but the rate at which it generates the signals is slower than SA node. SA node can generate signals at a rate of 60 to 100 per minute, but AV node generates the signals at a rate of 40 to 60 per minute. So it means that in case of SA nodal block, our second pacemaker will become AV node, but the rate at which it generates our signal, they will be a bit slower. Let's also talk about some drugs which can affect these action potentials, like beta blockers. Beta blockers are a kind of drugs which are frequently used by cardiac patients and those who are hypertensive. Beta blockers like propranolol block the beta receptors of epinephrine and norepinephrine. And the main phase of the SA nodal potential which is affected is phase 4. Beta blockers, they decrease the permeability of the SA nodal membrane to sodium and calcium. Hence, the slope of prepotential will be decreased. It will take more time to reach to the threshold value and the heart rate will be decreased. So it means by affecting the phase 4 of the SA nodal potential or prepotential by decreasing its slope, beta blocker drugs, they decrease heart rate. Which phase of SA nodal action potential will be affected by calcium channel blockers? Calcium channel blockers will affect phase 0, which is the depolarization phase. Hence, the depolarization phase will become even slower if a person is taking calcium channel blockers like verapamil. Which phase of SA nodal action potential will be affected by potassium channel blockers? Because potassium channel, they are responsible for causing repolarization or phase 3. If a person is taking potassium channel blocker, then the repolarization will be delayed. Now, in the end, let's discuss some MCQs. First question is about the ventricular muscle action potential. Which phase of the ventricular muscle action potential is responsible for the plateau phase? And the options are phase 0, phase 1, phase 2, phase 3, and phase 4. The answer is phase 2 is also called as plateau phase. And if I ask you the ionic mechanism behind this phase 2, so that will be because of opening of slow calcium channels. Next question is, what is the primary ion responsible for depolarization in the nodal fiber? And the options here are sodium, calcium, potassium, magnesium. The answer is calcium. So you can see here that during depolarization, this is calcium which passes through the L type of channels. This is responsible for depolarization. This is different from the ventricular muscle in which depolarization is because of influx of sodium. Now last MCQ is, which of the following is responsible for pacemaker activity in the nodal fibers? Options are rapid sodium influx during phase 0. Second option is potassium efflux during repolarization. Third option is slow sodium influx through funny channels during phase 4. And option D is calcium influx during the plateau phase. You will answer this question in the comment section. I hope you like this video. If yes, share it with your friends from various medical, dental, nursing and allied health sciences. Thank you.